All right. Hi, class. So I am here with Grace Javier, and she is an awesome Peds physical therapist and an awesome mom to boot. And we are going to get into her. She has a little presentation for you guys, and then I'm going to open it up for Q&A with her. So Grace, welcome. I'm going to share my screen to show off your fancy PowerPoint. So can you kind of just introduce yourself a little bit to my students so they get a kind of snapshot of who you are and what your job is, and then we'll go through your PowerPoint.
Okay, my name is Grace. I'm a pediatric physical therapist. I work for a program, it's a state program called California Children's Services. And we provide physical and occupational therapy for kids anywhere from the age of 0 to 21 who have diagnoses that have to do with neurological injury, and then a handful of orthopedic diagnoses like limb deficiencies or certain bone diseases. And so what we do as physical therapists for our program is not only provide like weekly or daily therapy to these kids that need to be rehabilitated, but we also provide services to provide them with medical equipment. So things like wheelchairs and walkers and bath chairs and things like that.
Awesome. Oops.
Next slide. Oh, there we go. So overall, just to go over what physical therapy is, physical therapists take pride in improving the way people move. So just like it says, we provide therapy to help you physically. So things that we consider ourselves movement experts. So we analyze how people move and we help them get back to moving to as close to normal or previous function as possible. We do that through things like exercise, hands-on care, and educating the patients. And in this case, for pediatrics, it's a lot of education to the family, the caregivers, and the parents. And why people may go to physical therapy. On a broader spectrum, physical therapy can be given to anybody that's had like any type of injury. If you've, I don't know, sprained your ankle or had a shoulder surgery or a knee injury, a lot of people tend to go to physical therapy, but more specifically for children, injury is a common reason. But in the setting that I work in, it's mostly children with disabilities and just health conditions in general. So the physical therapy can be provided in places like hospitals, in home, school, nursing homes, clinics, and also like in fitness gyms. So in a hospital, it can be given to a baby as young as like 2 days old. They can help and educate new moms on how to feed the baby efficiently if they were in the NICU. In the hospitals for older kids, sometimes it's a kid had a surgery and they need to teach the family how to care for them right after surgery. So we often can't send the kids home unless we know the caregivers know how to move them safely from the bed to the toilet or things like that. In home tends to be for the most of the time, the kids that are from 0 to 3, they go through a program called Regional Center, and they provide in-home services mostly for the kids that are 0 to 3 because they're the highest at risk for what we call developmental delay. In the school setting, the physical therapist is most responsible for making sure that the kids can access their school environment. So whether it's providing them with a walker or making sure that they have the right seat in class, that's going to help them learn in the best way possible. And then in nursing homes for the kids that just aren't stable enough to be at home. And then an outpatient clinic, which is a clinic like I work in, where kids and parents come and we do exercises with them, we educate them, and we teach them how to move better. So like I said, any pediatric physical therapy can be anybody that's from the newborn to age 21. Now, how to become a physical therapist. So now you have to have an undergraduate degree, and it can be really in anything, as long as you do your prerequisites to the specific PT programs that you want to apply to. Most of those prerequisites usually are anatomy, physiology, child development, and those are usually required to even just apply. Now to apply, it's usually like a centralized system, I think, called the PT Pass, and it's all one application online, and then you just like college applications, I think. You just check off all the schools that you want to apply to and go from there. Now, once you get into physical therapy school, it's usually about a 3-year program, and it's 80% classroom and lab time, and then 20%, which is usually like towards the end of your program, clinical internships. So that can usually you'll have about 2 or 3, and they last about 12 to 16 weeks, usually your last one. I know through CSUN's physical therapy program, we get students from there all the time. It's 16 weeks. So they spend the last 4 months of their program with us, pretty much just learning what it's like to be in the clinic, and to be, by the time they leave our clinic, they should be ready to work at a clinic. And we often hire them right after. But in order to actually work, you'd have to take a national board exam, and then depending on which state you're in, you take a state board exam where it's mostly about the laws, but the national board exam will ask you about pretty much anything and everything you learned in school.
Awesome. And so have you like mentored or taught PT students yourself?
As a licensed therapist, most places, like they have like an education program. So they'll ask you if you want to be what they call a CI, which is a clinical instructor.
Mm-hmm.
To be certified, you take a class, and they just teach you, like, what are the requirements for the students to pass, and how to facilitate learning in the clinical environment. And so when you're in PT school, there's also this like huge nationwide system where you have to apply for your internship, and then they assign you your internship.
Gotcha. So you don't get to choose. You have to kind of like match with somebody.
I don't know. It also depends on your school. Like when I was in school, we could talk to the clinical, whoever the head of the clinical education was, and we can tell them, I really want to do pediatrics. Is there any way you can find me one in this city? But really, it depends on each school. But yeah, you get paired up with a clinical instructor, and then you pretty much get graded by your CI.
Did you have to relocate when you were in physical therapy school?
I went to physical therapy school in San Diego.
Okay.
I'm originally from the Valley in LA. So I was in San Diego, and then I got 2 internships out here. So I got to come home for 2 internships.
Okay. So you did your coursework all in San Diego and then moved back to LA?
Yeah, I had 2 8-week internships out here in LA. So I came home and did those at St. Joseph Hospital, and then did a pediatric clinic in Torrance.
Okay. Awesome.
So within the subspecialty of pediatrics, there's different settings, like I talked about earlier. There's the hospital inpatient setting, like you see in that picture there, with a lady with a gown. Most likely that child is in the hospital for whatever reason, and they have clinics set up where they pull them out of the it's called usually like inpatient intensive therapy, where they'll have therapy pretty much every day. And they'll bring them to that clinic in the hospital. Or sometimes it'll be as simple as walking around the hospital because they're working on walking. If you look at the outpatient clinic settings, the more where you'll see kind of like a gym with a lot of mats and a lot of toys. And within the outpatient setting, there's settings like ours, which is like more neurological, orthopedic stuff. And then you'll see some clinics that are what we call sensory integration based. And those overlap more with occupational therapists, and they work on kids that have sensory integration issues. And what that is in general are kids that just have trouble regulating their sensory system. So sometimes if you've noticed some kids that tend to rock a lot or like to swing a lot, there are therapists that specialize in this area to help them regulate those things so that they can better adapt to their environment and learn more adequately. There's early intervention, which is, like I said before, usually through a program called Regional Center, and the therapists come to the home. And then there's a school setting, like you see here. Every school does it differently, but most schools for kids with special needs, they have what we call an IEP. And in the IEP, there will be physical therapy under there, and they'll have goals. A lot of times it's for the child to stand in a stander for 30 minutes a day during art or during PE. So they'll write goals like that in the school setting.
Awesome.
Like I said, in the hospital setting, there's the NICU. I did this once or twice while I was in school, and it was so cool because there's these teeny tiny babies. And you're just like moving their little arms. It's really cute. It's a little scary, but it's nice to see it's rewarding to be able to educate the parents on how to move these little babies. Post-operative rehab is like if a lot of kids that I work with have cerebral palsy, they tend to have a lot of orthopedic issues because their muscles are so tight that their hips will come out of place. And so they have pretty extensive surgeries. So we'll see them after surgery like that. And then there's acute rehab. And so some kids may have, unfortunately, like a stroke, may get in a car accident and have a brain injury. And those tend to be in places called acute rehab, which is, again, it's like it's not exactly like a big hospital, but it's like a smaller hospital where it's easily accessible for them to have therapy like 2 hours a day.
Yeah. So a lot of stuff post-surgery, it sounds like, though, like if a kiddo had a surgery and they need to, revamp an area that they had maybe surgery on and kind of thing.
Surgery and or some sort of medical event or like we see in my setting, spinal cord injuries. Could be because a kid fell off jumping off the bed and just landed wrong, or car accident. But those are also require some rehab.
Yeah, absolutely.
Again, the outpatient setting, you see that the picture of the girl in the wheelchair, that's very similar to the wheelchairs that I evaluate a lot of our kids for. Depending on the kids' abilities, we determine what kind of wheelchair they can have, and we monitor them for their from 0 to 21. So as they get bigger, we get them bigger wheelchairs, or as they get stronger, they progress out of a wheelchair. Now, again, that's an outpatient setting. In an orthopedic, more specifically an orthopedic outpatient setting, it's more kids that have normal cognition, but just broken bones or tight muscles, and are able to follow directions and things like that. In a neuromuscular setting, in like such as mine, there's things like cerebral palsy, brain injury, spinal cord injury. There's other diagnoses like muscular dystrophy, which is basically a progressive diagnosis where kids, based on their genetics, just get weaker as they get older. So it requires us to monitor them pretty much their whole life along their lifespan and give them the resources they need to be able to participate in life as normally as possible. Spina bifida is another neurologic diagnosis that I see a lot of, and that is when babies are born with their spinal cord kind of grown outside their body.
Mm.
When they're born, they have to have a surgery that has to take out that thing that grows outside their body. And so that pretty much creates a spinal cord injury for them at birth.
Mm.
And over the years, we educate the families and just kind of teach them how to live with their diagnoses and give them the resources they need. Sensory integration, like I said, it's mostly for kids that have autism and Down syndrome. Physically, usually they are pretty normal, like in terms of muscular strength and range, but it's more their ability to integrate in their sensory system to learn skills. So a lot of kids with autism can't regulate, sometimes loud sounds may throw them off, and so that doesn't allow them to learn skills like walking when they should. There's aquatic outpatient physical therapy, and that's done in the pool. And then there's hippotherapy, which is horse therapy. So there's physical therapists that just specialize in physical therapy given to children on a horse.
That's pretty awesome, actually. So sounds
cool.
very, very cool.
There's a place in Chatsworth called Ride On, and that's where they offer the physical therapy for kids on horses.
Yeah, that's awesome. Yeah, my program, we used to have therapeutic horseback riding for our kids.
Yeah.
But it was a little bit different. We weren't doing like physical therapy, but it was a lot of the sensory integration stuff. Kids that literally could not sit still at all, and they would get on a horse because it's a whole sensory experience for them. And this kid was completely calm, was totally centered, like chill. It was wild seeing him, like literally total transformation after getting off of the horse. It was really cool. So
it's definitely dual purpose from a physical therapy standpoint, because
yeah,
a lot of our kids have those issues, but also have physical issues. So, if we're working on sitting balance, your core will just get stronger if you're sitting on something that's constantly going around.
Yeah, no, it's true. A lot of that trunk stuff, right? A lot of our kids with like hypotonia, right? With a low muscle tone and their trunks aren't quite developed. That's a great way to kind of build it up, is being on a horse, right? So that's awesome.
Yeah. Early intervention, like I said, is usually in the home, and it's often due to prematurity, high risk for developmental delay. And that usually happens when, again, a baby's born very, very early before their due date. Oftentimes the baby can be at risk for developmental delay if they had some time without some oxygen during the birth. There could have been any reason during the birth that would put their brain at some sort of risk of delay. And like I said, this is through a program called Regional Center. And Nikki, you might know more about this than I do, but it's into adulthood, right? Regional Center.
Yeah, there's a big myth for a lot of people that it's only 0 to 3, and that everything falls on the school district after that. But it's lifelong. So regional center services, I mean, some folks get services into their 70s, right? If they have some sort of developmental disability. So autism, Down syndrome, cerebral palsy, things like that, or like some rare genetic disorders. But yeah, so a lot of the services like Grace was talking about, especially the pediatric PT, as well as like speech therapy, behavior therapy, and occupational therapy, are done in the home from 0 to 3, because it's easier, because the children are there, and it's easier for the therapist to go to the families when they're so young. And then after that, some of the services will transition to the school district, like you were talking about through the kids' IEPs, but also folks might see you like privately, right, at your clinic, or if they still need physical therapy services, and they might not be able to get it. So that's another thing that we're running into right now. And I know I shared this with you. A little boy that I'm working with currently is supposed to be getting physical therapy, but we can't find someone to service him at the school, unfortunately. So
a lot of things that we run into as well in this setting, because in California specifically, there's we're called California Children's Services, and we serve 0 to 21. But a lot of these kids with developmental delay, they become eligible for regional center, and if they come into our clinic before they turn 3, we're like, we're here for you, but if you would prefer to use regional center, that's totally fine. But once you turn 3, depending on their intellectual disability, they either get their service, like their services may end with the regional center because they don't have enough of an intellectual disability.
Right.
So there's that misconception, but like
Yeah.
it continues because they may have a physical and an intellectual disability after the age of 3.
Absolutely. And we were seeing that with the autism diagnosis for a long time, actually. And so they just recently, in the last several years, have changed the autism diagnosis to have more autism spectrum disorder, right? So, with autism spectrum disorder, the kids that are categorized as autism 1, right, which is the highest functioning, we're not getting regional center services, even maybe before 3, right? So, but now with the new diagnosis, we're seeing kids getting that are more eligible for other regional center services, which is really great because, they have a set of issues that a specialist might need to attend to. So it's gotten better. It's not great. It's still not 100%, but it's gotten a little bit better as the diagnosis has gotten a little bit more broad. But it's not a foolproof thing. So
We can get more into that later.
we can always get into anything with, good old bureaucracies and state funded things. And we talk about this a lot in my classes. And I want my students to really think about these kinds of things is like, you're going to get into a profession. You might not become a physical therapist, right? But you have to know what the job is because you might collaborate with somebody or refer to services because you can't physiologically do them yourself, right? And to know that there's these resources out there, like folks like you, Grace, and also just in general that some kids might need this at different points in time, and you might have to collaborate with those individuals. So they may not want to be a Peds physical therapist, and that's totally fine. But just knowing that there's different options out there and also referral bases to folks like you in the community. So
that token, like I would say, like as a physical therapist with CCS, I collaborate with school physical, occupational, behavioral therapists. We collaborate with the teachers, what we call assistive technology professionals, which are the people that work at the schools to make sure the kids have all the access they can to their curriculum, things like that.
Yeah. No, it's awesome. It's cool to be able to collaborate with a lot of different individuals. That's for sure. So it works better that way, that you can actually do that and collaborate with those folks.
Right. Oh, sorry. Hold on.
Sorry.
For some reason, I can't see.
You're just on the school setting and it talks about IEPs and 504 plans.
For some reason, your shared screen is gone.
Oh, no. Let me stop share and then I'll share again.
I don't know if it's because I got a call through my.
You probably did.
Connected on Apple and now it like screwed me.
Hi, your iPhone said, nope, sorry. It's okay.
All right. So this brings us actually perfect transition to education or school setting. When kids go to school, they have an IEP, more so in a public school setting. Some kids who don't have intellectual impairment or learning any ability, like any trouble with learning, are categorized as orthopedic impairment program. And so then theirs is mostly just making sure that they can access their environment. Some kids, the simplest kind of plan to have at school is called a 504. And sometimes that's because you just had surgery and you need to be able to use some crutches at school.
Mm-hmm.
The school always just wants to make sure everything's in the safest way possible. So they have things called the 504 plan to make sure everybody's on the same page. So yeah, school settings just mainly to access the school community or environment. And then sometimes they need to use specialized equipment like that, what we call gait trainer up there, so that the kid may not be able to walk on their own, but they can walk with something like that. And that puts them in an environment with their peers.
My little guy that we've talked about he uses a gait trainer as well. And he's pretty fast on that thing. Actually, it's pretty awesome to see him. He like races the other students with it. It's really, really cute. It's pretty awesome to see. So, all right. And these are just some references for the students.
So APTA is the American Physical Therapy Association. You'll find anything you need. If you're looking into becoming a physical therapist, CCAPTA is just the California branch. Cerebralpalsy.org is, again, like the website that tells you anything and everything about CP, all the resources you might need. And again, the program I work for specifically is, we are the go-to if your child has CP. So it's a state program, and every county has a CCS in California. And the main diagnosis is CP, but like I said, there's another sub list of diagnoses that we see. Yeah, that's it.
Awesome. So I'm gonna ask you a couple questions and then I'll let you go for tonight. I know it's Grace is a mom of 3 because she's crazy. So, and she finally just got her little ones to bed. So I'm gonna let her chill out in a little bit. My little one is in the bath right at this moment. So but just in general, I have just a couple questions for you, just so my students can have more time with you, but also just and I know a lot of them are going to ask things like this. So what would you say the biggest challenge for you as a pediatric physical therapist is?
To me, the biggest challenge is educating parents. And now that I'm a parent, it's easier for me to empathize with parents
Sure.
with special needs, because if I just put my parent hat on, I would want anything and everything for my child, and the best of the best for my child.
Sure.
But as a therapist, and it's not, I understand it's not always nice to hear certain things like your child may not walk, or your child may or may not do this, or you don't qualify for this service. Those are the hard things that we have to discuss with families and explain to them medically why it's not appropriate, so that's the hardest part, talking to parents and getting them to understand where we're coming from, because as a parent you just want the best for your child. So really bridging that gap is the hardest part.
And conversely, what would be the most rewarding for you?
The kids are the most rewarding part. No matter what, a smile out of the child, even in pain, is rewarding.
Yeah, absolutely. I mean, even when you're talking about, I'm thinking about like those little tiny babies in the NICU and just like moving their little body parts, like just like it's a cool thing to have that experience. So, and so for you, what made you personally choose physical therapy? Like what drew you to it initially, and why pediatric physical therapy at that?
Hold on one second. Sorry, one second. Okay. So I initially wanted to become a physical therapist because one of the common reasons why I feel like a lot of people go into physical therapy, it's like, oh, I played sports and I want to help people exercise, like through exercise and things like that. And so that's what I thought I wanted to do. When I graduated undergrad, I still didn't know I wanted to be a physical therapist. I changed my major like 3 times. And then my junior year, I was like, hey, I want to take a kinesiology class. And I thought it was really cool. And then I ended up finishing college in kinesiology. And then I was like, I still don't know that I want to be a physical therapist. So I was a physical therapy aide for like a year and a half. And I really and it was an orthopedic outpatient clinic. So we saw a lot of older people with back pain, people with shoulder injuries, more stuff like that. And that's why I thought I wanted to become a physical therapist. I wanted to help people get back to playing their sport or doing that. And then I that confirmed, I was like, oh, I want to do this. I want to help people get back to their lives. No idea I was going to work with kids. And then when I was doing my internship, I was like, I like kids. I like working with kids. I always was a camp counselor and things like that. So I was like, I'm good with kids. Let me just do one internship. And then I actually was like, oh, this was cool. Like, I liked it. And then when I graduated, I was like, well, let me just find a job. And so I applied in an orthopedic setting, like a sports setting, and then I applied in pediatric settings, and then that's where I fell into.
It chose you in some
Yeah.
way.
Yes, and I haven't left.
Yeah. Yeah. There's a reason for that then. I think you enjoy it just a little bit, right? So, if, and this will be my last question. So, for my students, most of them are child development students, handful of psych students, some public health, it just depends. Some random outliers, of course. If you had, your best advice, kind of, you thinking about yourself going through school and maybe getting a child development degree as this is what you were doing, what would be your best advice for my students to like motivate them or just kind of push them to go forward? Or if they wanted to do PT, what would your best advice for my students to be?
My best advice would be to, to determine if you really want to become a physical therapist, volunteer at a clinic, or like, I worked as an aide for a year and a half. I wouldn't recommend like thinking, well, this looks cool, so I'm going to apply to that for grad school. And then, hey, what if you get in? And then once you're in the program, you're in the program. Like it's intense. It's very intense. It was the most intense 3 years of my life. And you have to want it, so I won't lie to you. There were people in my class who finished their undergrad that summer and they started the next fall, and yeah, they knew they wanted to do it, but they weren't in it as much as I felt like the people that took some time to really learn about the field.
Sure.
And hey, like if you have that step ahead during your undergrad, you're an aide. There's a lot of, I know a lot of people that are aides while they're in undergrad. So, hey, get it done earlier and already know, that's great. But just educate yourself, put yourself out there and take the time to learn about the profession and make sure that wanting to help people is what you want to do.
Absolutely. Yeah. I've been telling my students this whole semester is to get out there and volunteer, find an internship or find an entry level job in something that you may want to kind of grow into as you, move forward in the field. So
I think once you do have that, you go into grad school feeling more equipped to even just deal with people.
Sure. And more confident, I think too, in your decision. And grad school is not cheap, right? It's expensive. It's like you said, it's very
you fail one class in PT school and then you got to go to the next school.
Yeah. It's expensive. It's intense. There's a lot of things going on. So
and then when you're studying, for me, my driving force was, well, if I don't know this, I'm not going to be able to do my job. So that was the driving force on needing to learn all the bones in the body and all the muscles in the body,
which is a lot,
like I did back then, but I know enough to make sure that everybody's safe.
That's a good thing. So, well, cool. Thank you, Grace. I just want to thank you for your time tonight, but in general and like all the awesome stuff that you do for kids, and also being an awesome mom too. I know our daughters are our bosom buddies, right? So thank you for taking the time tonight.
Of course.